Hi everyone, my name is Katie Oger. I am coming to you from Rock County Hospital's Trauma Bay. For this presentation, we will be going over airway management. My objectives for this course will be the EMS student will be able to verbally identify airway adjuncts utilized in deteriorating patients in the field upon visual request. EMS students then will be able to verbally identify one indication for each airway management strategy, and also EMS students will be able to verbally describe one contraindication for each airway management strategy described in this presentation. So at the beginning, as many of us know, being an EMS, airway management is what I would consider one of our more basic skills. We start very basic, we get very complex as we move up the airway ladder, but our first thing that we need to be able to do is to be able to look at patients and determine whether or not they are needing additional help with their airway status at that time. So what we're going to look at with our patients is we're going to look at their level of consciousness. Manny the mannequin is not very responsive. Hopefully many of your patients that you've run across are more responsive, are able to talk to you. That's one indication of having a patent airway, being able to oxygenate the brain to be able to answer questions appropriately, that sort of thing. This is all indications of how well they're perfusing and how well that perfusion is delivering the necessary oxygen that they need just for functioning in general. Then you're going to assess the patency of their airway. This is done in many ways, like I had just mentioned. One way to get a very quick description is asking them, hey, what's your name? And as soon as they're able to answer you, you know that they are breathing, they know that they are awake, and you know that they have an airway that they're able to utilize. So then you're also going to take a rapid respiratory status assessment. You can, again, do this very rapidly by looking at them. What's their color look like? What does their color look like? Are they able to answer questions appropriately? And then as you go into a more complex an assessment, you're going to be seeing their breath sounds bilaterally. You're going to be looking for any airway issues such as pneumothoraxes. In the field, you're not able to assess as much for like hemothoraxes, but some of those life-saving or life-taking rather situations that you want to intervene quickly and get control of. So after you've got your assessment done, you're going to be immediately looking at what is your next steps. So in the field, as everyone knows, we do not have an infinite amount of resources. It's either personnel issues, we're looking at equipment issues, so on and so forth. And so you always want to consider what do you have available to you and what do you actually need to get control of your airway. And then also how long of a transport do you have? As you get further into your assessment, one consideration that we have during flight, for example, is if we have a flight longer than 20 minutes, we will put a chest tube in rather than just needle somebody. And that's just a consideration. You don't want to be sitting there needling them over and over again, and considering with the altitude, that also causes some issues. So to begin, we have our most basic, if you would call it that. These are called oropharyngeal airways. These are used for unconscious patients, or rather patients that don't have a gag reflex. These are used to establish a tract of air, essentially. When you get someone that is unconscious, they get very floppy with their tongue. This kind of pulls it all forward. Obviously, you can only use it with people with the gag reflex, like I previously stated. Contraindication for this is if they are awake, don't try to stick this in their mouth. They will immediately tell you that that's not going to happen. Proper sizing is very important with these. You're going to be looking at the tragus and you're going to be looking at the corner of the mouth. So this is a correct size for this patient. As far as getting the airway into the airway, it depends on the accepted route of placing this is you're going to either put it in and then turn 180 and then place. You could also hook it in, get behind that tongue, and then put in. I have never had great luck with the 180 turn, just because I feel like you got a lot of trauma going on there. If they are truly unconscious, gloved hand of course, I will, of course, double check that they're unconscious, and then I'll just grab that tongue, get it off to the side, look in, place it, make sure that my tongue's in an appropriate spot, and then leave it. We will utilize these for just the regular bag valve masks, ventilation that we do. Also, when we are getting ready to RSI a patient, I will utilize this just so that way when I'm pre-oxygenating them, I feel like I just get a better track to add some pressure to optimize their oxygenation prior to intubation. To remove, if you get that far, you're just going to spin that out. We generally don't remove these too many times in the field unless we move to the intubation route. But kind of once these are in, you're just going to leave them in, not move them around too much. On to our next. So these adjuncts, of course, are helpful in many different ways. I should make mention, just due to the COVID situation, all airway supplies are incredibly difficult to get a hold of. So the things that I have available, I'm showing you. Otherwise, I will be showing you them in a package. I'm not able to, I don't want to rather take them out of the package and waste them. So for this, just for the sake of presentation, I'll be more describing the NPAs. This is an NPA. This is our largest at a size 34. This is utilized for patients that you're not able to use your OPA on. So awake patients, but I shouldn't say awake. Patients that are able to control their airway to a certain extent that they are able to maintain their gag reflex, but yet they're still not able to maybe follow commands. One place that people like to utilize these is when you have an intoxicated patient. So as you may or may not be able to tell, that bevel there is for quite a large gauge of the passage there. It just it doesn't feel good going in through the nose, I've been told. I've never, of course, had one done. But simply you take lubrication, make sure to be nice to your patient, you get that very well lubricated. You take the bevel edge and you put it on the inside of the nair. So you're going to put bevel side in, you're going to twist it in, and it's just going to follow that track, if you would, back to the back of the throat and then down. And so it'll sit not past where your gag reflex is initialized, if you would call it that. So King's tube, again, I do not have one of those, and they're on our crash cart, and I'm not going to bust open a crash cart to get a hold of those. I did include a picture on the slideshow that I'll be presenting, or I'll be publishing along with my presentation. These are considered rescue airways to an advanced provider. It is also considered a BLS airway. So depending on where you are practicing or what you are receiving, they're not always considered rescue airways. So those are based on the patient's height. And they originally came out for adult patients only, but now they have gone to all the way down to neonates. So they're very helpful. They're quick to place. You place them just the same as you would a combi tube, as many people are very familiar with those. I see that they're kind of starting to come out of practice in a way. But you just essentially, again, if they're needing a crash airway, they're going to be very they're not going to be conscious. And so generally what I do is I try to get a hold of that tongue with my patient, grab a hold of it, put in the King airway, and then there's one inflation, kind of like an ET tube, one inflation port that you put 10 cc's of air in to secure that airway. Once you attach the BVM to it, you want to start making sure that you in fact have it in the correct place. You will know that based on the fact that you get some chest rise. If you don't get chest rise, this is something that took me a couple of years to kind of figure out. If you're not getting chest rise, rather than taking it out and trying again, you're in the right spot. You just may not be in the most optimal spot. So as you are ventilating, if you are able to kind of pull that king tube out, once you're able to ventilate or compress that BVM bag, then you know that you're in the right spot. At that point in time, if necessary, you can add a little bit more air to secure that airway. But otherwise, it was just kind of a neat little trick that I had found. But again, like I said, many paramedics that are receiving or mutual aiding a patient, they will see the king tube and immediately assume that they had just failed their airway, and that may not be the case. So, all right, so as we move forward, I mentioned ET tubes many times already. Our ET tubes are the same as everyone else's. Again, we do not have one that's open and available, but I did want to make mention of the fact that there are many different ways that you can place an ET tube. So the upcoming or very well accepted practice, we're getting away from the blades just because the blades proved to be a little bit more difficult, and we're really looking to get that 100% pass, first time pass rather. And so this is a very large blade. This is what we use for training. I believe this is a 4 Mac. And so with this, you have to be very aware of how deep you're placing it. A lot of people will shove this all the way down as far as they can go to get that in, to get the visualization of the vocal cords, but many times they actually get past those vocal cords and all they see is just a bunch of pink skin. And so if that's what you're seeing, again, kind of like the king tube, you're just gonna ease your way back until you get a good visualization of those cords. Also, people use what's called glide scopes. Glide scope goes, depending on your facility or your ambulance. We can also use the King Vision, which is very helpful. I personally like the glide scope just because I feel like you get better visualization with it. And so again, that's kind of used kind of like the blade, except you would have this attached to either your monitor in the emergency room, or there's actually a little video that sits on top of these. And again, that just goes in the same way. This is a 3, so this is actually an appropriately sized option. One thing I do want to make reference to is these airway heads don't make it super easy to really optimize your positioning. It wasn't until I became part of flight did I kind of stop struggling with my intubations, because I discovered that I've been positioning wrong this entire time. Everyone knows the old head tilt, chin lift positioning, but when you are trying to get good visualization of those cords, I found that when you actually raise the bed, you get that 30 to 45 degree angle, kind of depending on your patient. All of a sudden, what was a very difficult airway becomes a very easy airway, even with the old school blades. I haven't missed an intubation in 2.5 years using this method. Not bragging, just saying. But it does prove to be very effective. Prior to that, I was running about 50% first pass success. And so it seemed as though raising the head made all of the difference. So ET tubes, they range all the way from premature babies all the way up to very large people. Those are the accepted, essentially the accepted sizing past pediatric is about 7.5 for women and about an 8 for a man. Of course, that is dependent upon the provider's skill level, also along with the patient presentation. I do recall a time I had a very tall man. He had inhalation burns, and by the time we got to him, I was only able to pass a 6.0 tube, so barely what you would even call a small adult tube. So that, of course, was not optimal, but at the same time, it's what we had, and it was effective for what we needed it to be. So when you place an ET tube, you have quite a few things to consider, but if you do have a few benefits, it protects the airway from aspiration. Anytime that we have any sort of overdose, any sort of intoxication that decreases the level of consciousness. We're definitely looking for that just due to our nature of flight. In the ER, you could be a little bit less aggressive when it comes to those tube placements. Also, it provides an alternate route for medication. So when you're in that code situation, you can drop your medications such as epinephrine down the ET tube at a much higher quantity, but still nonetheless you can get what you need someplace that it can be utilized. And then also pulmonary toilets, which most people don't think of at times. So when you got a really junky patient, I've actually placed a tube for no other reason than to just suction everything out of there, take out that tube. And that was kind of a different situation as far as methods in order to get that tube. It wasn't a typical RSI placement, but nonetheless, it was still very useful. So as we have kind of gone through some of the equipment portions of the airway ladder, I kind of feel like this is when things go wrong. This is the tool that a lot of people underestimate as far as its usefulness. In my mind, this is a BLS ventilator. And so, you have your mask, of course, if they're not intubated or you don't have your King's tube or combi tube or, the LMAs or the 10 things you can hook up to these. But you could also add a PEEP valve to these, which is incredibly helpful when you start bagging patients. When you let go, you're essentially losing all your alveolar recruitment, which then it just in turn makes the entire process so much harder. This does not have a PEEP valve on it, but I did want to make sure that I made reference to it in this presentation. And so, as everyone knows, this is very hard to do, just a single provider. A lot of people kind of shy away from really getting aggressive when it comes to ventilating these patients and making sure that there's a good seal. But everyone knows the CE method, and so being able to really, rather than push down, you want to pull up. So as you can see, I can really grab a hold of that jaw. I wasn't real aggressive until I had a CRNA tell me, like, you need to get a hold of that jaw, you need to pull it up, and it didn't hurt the patient. And so again, this mask, as everyone knows, can come off, goes on tubes, etc., etc. One thing that's nice about these is that you can actually ventilate a patient with your PEEP just as well as you could with a ventilator with the right technique. You can get up to 100% FiO2s. Again, those PEEP valves, you can get up to, I believe, 20. So again, if you have a good understanding of how these are used and how you could use them in your practice, you can have great outcomes with them. So, as we've kind of talked about some of the different things that you may utilize during your oxygenation ladder step through, now it's kind of time to talk about the actual ladder itself. So oxygen therapy in itself, every patient that you run across uses oxygen therapy, if you would think about it that way. Me, I'm on room air, but I'm still utilizing 21% oxygen, if you would say that. I'm not needing any intervention right now. I'm not distressed. I'm not short of breath, etc., but still nonetheless, if you think about it, you're still utilizing oxygen therapy. And so looking at your patients, being able to tell where they are in their oxygenation and ventilation support is going to kind of direct you on where you're needing to go. So starting with the lowest, if you would say, utilization, it's a low flow oxygen delivery system. It's our nasal cannulas. Everyone's very familiar with these. These are a basic skill level tool. So again, this is the low flow oxygen delivery. And so this will be utilized if you're using 1 to 6 liters per minute. And so that'll actually give you an FiO2 of between 24 and 45% FiO2 delivered to your patients. These are used when you are just needing to add some oxygen to the ambient environment. The one thing that you would use this for as far as an indication, again, is just a falling SpO2, but a normal end-tidal CO2. Once this becomes inadequate, that's your contraindication. You're not going to be able to use these for patients that are in severe failure. And so once they kind of step out of this, that's when it becomes a contraindication. But as far as anything else, you're going to be looking at, facial trauma, anything to make it so this doesn't add anything. So if you have a face blown off or something like that, putting a nasal cannula on them isn't going to help. Granted, it's not going to hurt either. So, so as you get moving kind of through the oxygen therapies, you want to consider, again, what do you have and what do you need? Next step that you're going to be going through, you're going to be utilizing your simple mask. This is just going to increase your FiO2. Same type of idea as your nasal cannula. This is just going to increase the ambient oxygen in the environment. So the oxygen will be available when the oxygen CO2 exchange happens in the lungs. A contraindication to this is just a failing ability to utilize that oxygen. Indication is just like the nasal cannula, is just needing an increase in FiO2 in your environment. As we move up, we've got our non-rebreather. This is again used to increase your FiO2. This can actually be used, they say, up to 100% for your FiO2. I've also heard that that's maybe not the case, but it's due to whether or not your valves are covered, and then how tight your seal is. And so if you've got a real loose mask, you're not going to be able to reach those 100% levels that you may be trying to achieve. You're going to want your liters per minute to be over 10. If you're just on the regular wall oxygen, that is to make sure that they're not rebreathing any CO2 that they're exhaling into that mask. And so keeping a lot of air moving through the mask is what's key about that. Contraindications, again, this is just increasing your FiO2 in your environment. This doesn't add any support in any other fashion. So once they become, essentially once it becomes a ventilation issue rather than an oxygenation issue, this becomes irrelevant at that point in time. So we as in our EMS and our ER here in Rock County utilizes these CPAP masks. I have included a picture in the slideshow to give you an idea of what that looks like actually on a patient. These are incredibly helpful because these you don't have to have the machine for. You just plug these straight into your wall oxygen, and based up on your liters per minute is how much pressure you're actually going to give. So you can actually give up to 25 units of pressure on that patient. And so very helpful in the EMS world, very helpful in our ER that we don't have a lot of resources in a rural hospital, but nonetheless we can give them some of that support. This is a method that is used for when you have that falling SpO2. They don't necessarily have a ventilation issue, but they may be having failing oxygenation issues. So when you start looking at heart failure, when you start looking at fluid in the lung, that type of a thing, when you have that shunt that's sitting at the bottom of the lungs and they're needing maybe some support on top to push that oxygen down in, or to push those fluids back into the capillary spaces so that way that exchange can happen, that's when you're going to be looking at this. You get a little bit more risky as you move up the scale of your oxygenation ladder. So one thing that has to be present with this is they have to be spontaneously breathing. And then another thing is if they're nauseous, I will not put this mask on them. If you take a look at the picture in the presentation, there you can see that it's just really attached to this phase. It's not a quick release situation, and so it actually goes for a way to hold that mass down and get a really good seal. So you're getting that pressure that you need, but you're also increasing your risk. And so if I put this on anybody, if they're sick enough that they're needing this in our ER, in our ambulance, or in our helicopter, I'm giving them some Zofran or something along those lines to help prevent them vomiting in that mask and then creating an aspiration issue, and then now you're down a whole other another track. But you're going to start at 5 generally. That's kind of our innate PEEP, if you would call it that, the pressure that you need in order to keep those lungs semi-inflated. And then you're going to do stepwise up into what you need in order to oxygenate your patient. So generally what you're looking at, most people are pretty comfortable getting up there to about 10, 15. Once you start getting into 20s, that's when you start worrying about barotrauma, and you start worrying about needing some other type of intervention there. I don't have a BiPAP mask here because we do not use that here in this ER. We will be using it shortly, which I'm very excited about, but I utilize that on the helicopter. And so BiPAP is more for ventilation support rather than the oxygenation. So if you have somebody that's really failing both on the inhalation and exhalation fronts, you can utilize this. We've been using it a lot in COVID patients just because they just need that constant recruitment of the alveoli to keep those shunts away, if you would say that. Starting values as far as the Revell is a 6 and 16. So 6 for your exhalation and 16 for your inhalation. And then you're going to titrate your FiO2 based upon your oxygenation needs of your patient. Again, same method uses CPAP. Those are very secure masks. They are actually sized from the bridge of their nose to the bottom of their lip to their chin, depending on their patient. Sometimes they don't have much space there. A lot of people will just look at the patient and say, oh, that's a big guy, we need a large. No, that's not the case. And then you'll have an ill-fitting mask, which will cause a lot of issues as you go. Not a lot of detail about BiPAP, just because a lot of people, you're starting to get into that critical care management at that point in time. But it is something to consider if you do have a ventilation issue, but you still have a patient that is awake and able to breathe on their own. You don't want to just dive for the tube, and especially in these COVID days, you find that we're really shying away from the tube just due to the fact that once a tube gets placed, it's very hard to get it back out. So there is kind of my spiel on my BiPAP. Again, some things you need to consider. Do not place a BiPAP on a patient that's not able to breathe for themselves, and also do not forget to pre-medicate for nausea and vomiting. Again, you don't want them aspirating vomit that they've just thrown up in their mask. And let's see here. So finishing up, we're going to talk a little bit more about the ET tube placement, the actual intubation process. I'm not going to get into the RSI spiel because everyone does it very different based upon your program, based on what you were taught. Essentially, like I say, how you were raised is how you're going to intubate. I like to go down the 7 P's, the pre-oxygenation preparedness, that whole spiel, get your rescue airways, et cetera, et cetera. Again, I'm not going to go through all of that. But the key thing to remember is that once you place your tube, especially in an RSI fashion, some of the most important things that you're going to want to consider, especially in transport, is you're going to want to consider your sedation first and foremost, and then if you're going to be utilizing high pressure supports such as high PEEPs, etc., it's not very comfortable for the patient, so you're going to want to be considering pain management, and you're also going to want to consider paralytic if that's something that is necessary for your patient. One of the things that are great about your endotracheal intubation is that it provides you the opportunity to control everything about this patient's oxygenation and ventilation. And so you can really use some different methods in order to oxygenate this patient well, to ventilate this patient well, and get some really great outcomes as far as that's concerned. Again, I won't get into the details of that. I did want to make a mention of the fact, just due to the fact that we talked about intubating patients, love me a good bag valve mask, but sometimes that's not always adequate. So some programs, some hospitals are able to use ventilators. And so just very quickly, two very common ventilator settings that we see out in the field is a volume assist control. So with that, you're going to be setting your tidal volume based on ideal body weight, and you're going to also be setting your respiratory rate, your FiO2, your PEEP starting usually at 5 depending on your patient condition, and you're going to be monitoring the peak inspiratory pressures, which is your bronchial pressures, and then your PEEP flats, which is your alveolar pressures. And so with that, you want to make sure that those PEEP flats are below 30. You don't want to risk any barotrauma. PIPs are kind of the same way, that the peak inspiratory pressure, you're going to want to kind of keep those below 30 just to make sure that there's no trauma being done at the very lower levels of the lung. Next one that we're going to talk about is the pressure support assist control. And so this is a little bit different in the aspect of the way that you set this up. You're going to set up your initial PEEP. So again, based on your patient presentation, generally starting at 5-6, give or take, and then you're going to set your pressure support on top of that. So essentially you are setting your PIPs or your plateau pressures at times. Again, you want to keep those below 30, but at the same time, this method is monitored by tidal volume. So if you have a patient that doesn't have great lung compliance, you're going to need those additional pressures in order to gain control of that compliant lung. And so as the lung becomes more compliant, which generally it does unless you have an RZ situation going on, you will actually turn that pressure down as you transport. And so along with the pressure support and PEEP, you're going to set your respiratory rate and your FiO2 as if you would in the volume assist control. And so with that, you get, in my opinion, better outcomes, and it is a little bit safer as far as transport, in my opinion. Again, just my opinion. The pressure support is very accepted for pediatric transports, and so if it's good for kids, it's good for adults too, right? So while you are ventilating this patient with the pressure assist control method, you're going to be monitoring for your exhale tidal volumes. If you start getting, based upon ideal body weight, that's kind of where you want your idea. That 6 to 8 is what's accepted through ARDSNet, if you're familiar with that. And even then you can go as low as 4 if necessary. But you want to kind of calculate kind of your target exhaled tidal volume based on your ideal body weight. And then you want to monitor what your ventilator is spitting out for numbers as far as that exhaled tidal volumes. If they're too high, you want to turn the volume down, turn the pressure down. If they're too low, you want to turn the pressure up until you can get where you need to be. So in conclusion, we've gone through some different equipment that you use for your airway management, going from all the way from your nasal cannula all the way up to your intubation, as well as your adjuncts such as your OKs, NPAs, keying tubes, etc. We've also gone through some of the different types of ventilation or oxygenation support that you would use from low flow all the way to endotracheal intubation. You do have your rescue airway, if you would call it that, of a crike, which I'm not going to go through today, just due to the fact that I wanted to keep this fairly basic. And then also we went through and discussed 2 types of ventilation that you would see on an actual ventilator that you could utilize for patients that are in your respiratory distress situation. So a few things that you want to consider is airway is something that you consider in every patient at every level. And so every patient requires airway assessment and management. It is the degree in which you intervene that you must consider for your patient. I think that's all I have. I'm sorry I went so long. I was hoping to keep this to about 15 minutes. So if you have any questions, let me know. I have attached my slideshow, and that will be posted below the video. So thank you so much for your time.